Hello everyone, my name is Ho Yang Wai Brian. Today I'm going to have a brief talk about major depressive disorder, one of the DSM diagnoses in mood disorders. Yeah, why do I choose this topic? Very simple, it's because major depressive disorders are all around us. As you see, when you see in Europe, there are 5 to 10% of the people are actually major depressive disorders patients. So how about in my hometowns? 5 to 3%. So meaning that many people with major depressive disorder is around us. According to WHO's, depression is already one of the most common mental health disorders, and it is also one of the most leading cause of disability in the world. And actually, globally speaking, 300 million of people is suffering from major depressive disorders. Yeah, one of the DSM diagnoses in mood disorders. Now let's have a look on the symptoms or the assessment process. In DSM, I try to use DSM because it is the most commonly used in Hong Kong, my hometowns. And this called categorical approach is quite relatively simple. It just talks about the collection of symptoms. If the amount of symptoms reach a certain level or meets the criteria, then the people are very likely can be diagnosed as major depressive disorders. So now let's have a look on the symptoms. Criteria. So for the criteria A, the persons need to have 5 out of 9, at least 5 out of 5 some of the following symptoms for more than 2 weeks. And the symptoms cause the people have significant function deficit problems in functions. So the first symptoms it was depressed mood in most of the days, and the next symptoms is loss of pleasures or diminished interest. Now be careful that the first and the second symptoms must be fulfilled in order to diagnose the patient with depressive disorders. Now, another symptoms can be significant weight loss or significant weight gain. All these things. Both of them can be symptoms of depressive disorders. Insomnia, they sleep, can't sleep, or hypersomnia, they sleep too much as compared to the past. Psychometric agitations, the patients may feel too restless, they can't slow down, or retardation, they can't move. Fatigues, loss of energies in all of the days, they have no power to move. Feeling of worthiness or excessive inappropriate skill to another days, very simple. Diminish the ability to think or concentrate. They can't work. They can't have cognitive functionings. Recurrent thought of death, recurrent suicidal with suicidal plan. Yeah, the patient talks about the death, or they tell you that they want to die, they want to kill themselves. They have a plan, but they don't have a plan, just a big ideas. Also count these symptoms. This symptom must cause clinically significant distress in social settings or occupational settings or other important areas. Meaning that if he is a student, his GPA drops significantly. If he is an employee in the companies, his work performance drops significantly. The episode is not attributable by other physiological or substance or medical conditions. Yeah. Don't think because some medical conditions like brain tumors can also cause depressive symptoms. The occurrence of major depressive disorder is not is not explained by other psychiatric disorders such as schizoaffective disorders or bipolar disorder, because these are the possible differential diagnosis. We need to rule out it because before we diagnose people with major depressive disorders. Assessment strategies. The first step must be established report. Why? Because according to this classic research, empathetic understandings and the expectancy of the patients contribute a very major portions of the process. And of course, the assessment process is also included. So that's why we need to have established report with clients. Demonstrate empathetic understandings, active listening, unconditional positive regard will be helpful. And of course, need to kind note your credential experiences, your training backgrounds, and your approach to the therapies will also be can also facilitate the assessment process. For me, I tend to use OCAS as one of the assessment strategies because it helped me to understand the symptoms better. Sometimes I will consider the use of standardized psychometric tools to assess depression, such as back depression inventories. And of course, don't forget to assess the suicide risk because usually people with depressions or major depressive disorders will have some suicide risk. Do not include symptoms that are attributed to other than, we discussed it. Consider obtaining clinical information from others if the client's a child, or actually not only child. We as in the diagnostic process, we accept the subjective report of the clients. For example, they say, I feel unhappy. Now, this is subjective experience of the patient. We also accept the objective observation of others. For example, if I observe that this guy is tearful, then it also counts as depressed with the first diagnostic criteria. Other differential diagnosis that we talked about it. Also consider positive reaction to significant because bereavement also demonstrates some depressive disorder symptoms, but they generally will diminish over time. But for major depressive, they are less likely to diminish over time. Compare and contrast the symptoms with cultural norm. In different cultures, they will have different expressions on the depressive symptom. For example, as a Chinese, many patients will demonstrate somatic symptoms instead of psychological symptoms at the beginning. So if we observe that this person has a lot of somatic complaints, I will pay more attention. Now it talks about it. The therapeutic process, I choose cognitive therapy to treat the patients because this is one of the most evidence-based therapy for depressions. Simply speaking, CBT thinks that the activating events or the stress that doesn't cause the people feel depressed, but they feel the belief system make the people feel depressed. For example, if the belief system has too many distorted or maladaptive thinkings, that will cause a negative consequence, such as negative emotions, depressive mood, sad, or even suicidal behavior. One of the most famous cognitive therapists, he identified that people with depressions usually demonstrate three major kinds of distorted belief. He finds that the people with distorted perceptions or belief over the futures, distorted thinkings about the world, and distorted thinking about the self. So the therapeutic process will be identifying the activating event or the stresses, and then identify the maladaptive belief system. We talked about it, the distorted thinking pattern of self, world, and futures, and investigate the relationship between the belief and the consequences. Let's say the depressive mood or suicidal behavior. The next thing will be help the patients to dispute whether the belief system is scientific, is unrealistic, and non-functional. If the patients can identify and realize that his or her belief system is distorted or the malfunctionings, then they're more likely to think about or rebuild or a more healthy, functional belief system, and then the symptoms will diminish. Finally, we will evaluate the therapeutic process with the patients. That's the end of my presentation. Thank you.